This lecture is on eyelid cysts, and I am going to give you a sort of a resume of all types of lid cysts and how we classify them. Just a reminder of the primary skin lesions: the macula, the papule, the nodule, the tumor, the plaque, the wheal, the vesicle, the bulla, and the pustule. And the macula is just flat, may occur in freckles. The papula is solid elevation less than 5 millimeters. Between 5 and 10 millimeters, it's called a nodule. If it is bigger than 10 millimeters, it's a tumor. And if this elevation is flat, it's called a plaque. If it's surrounded with dermis edema, it's a plaque. It's filled with fluid, it's a blister if less than 5 millimeter, and the bulla if bigger than 5 millimeter, and is a pustule when filled with pus. Secondary lesion are scales, where conified skin occurs in flakes. If covered with dried exudate, it's a crust. If there are cracks, it's a fissure. If there is denuded epidermis, it's an ulcer. If there is excess collagen inlay from fibroblast habituation, it's a scar. And if there is a loss of skin structure, it's an atrophy. Now, a cyst is a sac with a membrane that has a cavity and contains fluid. So by definition, a sac is a thing that has a cavity. So here, all these are not cysts, but a vesicle, a bulla, and a pustule might be a cyst. All the secondary lesions are not cysts. So it's a cavity containing structure with a membranous covering, and it contains fluid. Very different appearances that you encounter every day, from white to skin color to multiple to reddish to black to just an elevation to big ones to opened ones to crusted ones to translucent ones to vascular ones. These are very common that we see every day, and to every practitioner, there is a confusing pathology that I'm going to sort out in this lecture. What do? You excise. Do you biopsy all the time? I don't think so. Anatomically, they may occur in the skin, in the muscle, in the tarsus, in the conjunctiva, the 4 well-known layers, and in the margin. So the cysts might be skin, muscle, tarsus, conjunctiva, or margin cysts. Etiologically, there might be congenital, resulting from trauma, resulting from inflammation, or from a neoplasm. So congenital, traumatic, inflammatory, neoplastic are the etiologies. Pathologically, we consider them as primary, secondary in another lesion, or a cyst in MS. So the classification again, in the skin, muscle, tarsus, conjunctiva, or margin, this is the anatomical classification. Pathologically, might be primary, secondary, or in a mass. And the commonest cysts are those in the skin, in the tarsus, in the palpebral conjunctiva, and in the lacrimal gland. So the skin cysts are those 10 ones: pseudoreferous cyst or hydrocystoma, sebaceous cyst, milia, apocrine retention cyst, chromhidrosis, epidermal inclusion cyst, cystic hemangioma, cystic arteriovenous malformation, hemorrhagic cyst, tricholimal cyst, or cystic variant of basal cell carcinoma. What is a hydrocystoma or pseudoreferous cyst? By the way, this is extremely common. It occurs in the sweat glands with a thin, transparent wall filled with fluid. We described it, if you remember, in the histopathology of the eye. It's filled with clear fluid, just thus looks a bit translucent, and it's called a hydrocystoma. And if you take it out, if you excise it and trans-eliminate it, you find it translucent like this. Now, a sebaceous cyst may occur in one of the sebaceous glands associating the hair follicle, and they look more opaque, filled with, on the contrary to hydrocystoma, these are filled with oil. They look opaque, not translucent like a pseudoreflux or a hydrocystoma. This is another sebaceous cyst in the margin. And these here in the canthus. This is occurring in one of the glands, the sebaceous glands of the skin. And here in the margin, in one of the sebaceous glands of the lashes. Again, a marginal sebaceous cyst, a skin sebaceous cyst, another sebaceous cyst. Now we come to milia. What is milia? It's an epidermal keratinous cyst that occurs in multiplicity with tiny white heads, common in neonates, and disappears spontaneously. Adult variety may take longer. Here they are, multiple small white cells, keratinous in nature, but is filled with keratin. Usually multiple, and in adults, they take longer to disappear. An apocrine retention cyst is a chrome hydrosis retention cyst that is colored. And this coloration is of obscure etiology. Epidermal inclusion cysts, where the epidermis has keratinization inside, and these are called the epidermal inclusion cysts. They are different from milia, and the difference is in color, size, and they are not usually multiple. These are the epidermal inclusion cysts. As you can see, filled with keratin. Hemangioma is by definition cystic in nature. An arteriovenous malformation is usually misdiagnosed. You only diagnose it when you excise it and try to stop bleeding. You cannot. So one like this, if you suspect arteriovenous malformation, you should do an angiography. Find the feeder vessel, and this is the one you have to tie with a knot or cauterize to prevent excessive non-stoppable bleeding on operation. This is a hemorrhagic cyst, and we described in the orbit the difference between a hemorrhagic cyst and a cyst and hemorrhage in a cyst. A hemorrhagic cyst is where the blood accumulates, making a hematoma, and this hematoma is more compressed in its center, where the center is necrotized and lysozymed into a fluid with a pseudo capsule. This is called a hemorrhagic cyst. But if you have anything else and trauma caused hemorrhage in it, like a hydatid cyst or an epidermal inclusion cyst, or even a milia where with hemorrhage inside, this is called cyst or hemorrhage in a cyst. So this is the difference between a hemorrhagic cyst and a cyst. I'm sorry, I always say cyst. So it's either a hemorrhagic cyst or hemorrhage in a cyst. Now, another variant is the trichilimal cyst, where triche means a hair, and limal means a membrane. So this is a cyst that occurs in the outer root sheath of a hair follicle. It's rare in the lids and is reported to masquerade as a chalazion. You can diagnose it as a chalazion, but pathologically speaking, in histopathology, you find it filled with keratin and proliferated epithelium covered by skin, as you can see, and around a hair follicle from the outer sheath of the hair follicle. Now, muscle cysts, all these were the 10 skin cysts. We come to the muscle cysts, where either a hydatid cyst may occur from the scoliosis of the Echinococcus granulosa worm, or a leiomyoma, a benign tumor from the smooth muscles, or a sarcoma from any of the muscles of the eyelid. Tarsal cysts are the chalazion, the intratarsal keratinous cyst, and the tarsal dermoid. Multiple chalasia inflamed after treatment and intralesional injection. It's a chalazion, another chalazion in a child, and a granuloma pyogenica, where the chronic inflammation with pus formation caused a formation of a granuloma, not granulomatous inflammation, a granuloma with admixed fibroblasts and pus cells. As you can see, this is a granuloma pyogenicum. A granuloma pyogenicum here is occurring around the puncti after trial, very bad trial of dilatation. And when excised, it was found the granuloma pyogenicum and the puncti and calaniculi were repaired. Now we come to intratarsal keratinous cysts, and this is a variety of tarsal cysts. They are usually smooth, white, stratified squamous epithelium cysts without a granular layer, with no inflammation, and you find string-like keratin inside. This is an intratarsal keratinous cyst, and this photo is from the MS thesis of one of our colleagues. As you can see, it's elevated whitish within the tarsal plate, containing stratified squamous epithelium and keratin, and has no granular cell layer. This variety is usually misdiagnosed as a PTD. Might be multiple. As you can see, this is not follicular conjunctivitis, being whitish and elevated, but very difficult to diagnose clinically. You have to have a biopsy and pathology examination. Now, marginal cysts are sebaceous, cyst of Zeiss, epidermal inclusion cysts that we have just described. You remember the dark ones? I don't have to go back. Pseudocystic pleomorphic adenoma or cystic papilloma. All these can occur in the margin. I'm going to describe the pseudocystic pleomorphic adenoma and the cystic papilloma. This is a pleomorphic adenoma at the lid margin with pseudocyst formation. And this is a papilloma, sort of a wart with bossy, multiple bosses, multiplicity. The surface is not smooth. And finally, we come to inflammatory cysts, and we describe hordeolum, abscess, granuloma pyogenicum, and necrotizing fasciitis. And by hordeolum, we have hordeolum externum, that is a stye infection of in one of the hair follicles, and internum is an infected chalazion. Hordeolum is the term given to acute inflammatory cysts for a stye or infected chalazion. An infected chalazion is internum, being deeper in the tarsus, or externum, being in the hair follicles. And the usual abscess, which is localized acute how do you say it, pus formation, cyst, and granuloma pyogenicum, which we described, and finally we come to necrotizing fasciitis. This is an abscess. This is another abscess, and by necrotizing fasciitis, we speak of inflammation of the deeper hypodermal superficial fascial layer with an immunological liquefying reaction that is caused by organisms or sometimes even just as a reaction. I must remind you that this is a sometimes very difficult to control and even deadly. An adnexal cyst may occur in the lacrimal gland, and it's a lacrimal gland cyst is diagnosed by its location and on a CT. And here, this is a graph from Dr. Mayar Salah thesis, where she gave us the incidence of the different cysts in our society, patients of Demirdash. And as you can see, in a study containing around 60 patients, the commonest was a chalazion, followed by an internal hordeolum that is an infected chalazion, and sebaceous cyst, and apocrine hydrocystoma, which is the pseudoreferous cyst, and cysts of Zeiss. Thank you very much.